In awe of the turnout. Thank you for coming, and especially to the men for coming as well. As Peter alluded to, when I started my career, our belief was that heart disease and stroke, which I'm referring to here as cardiovascular disease, was a man's disease. And I really began to recognize that that is far from the truth. I don't know how many of you know what women are most likely to die of. Any?
Heart disease.
Yeah, it is. Most of us, myself included, are terrified about breast cancer, but we are much more likely to die of cardiovascular disease. And so there was a huge gap there. We had very much viewed cardiovascular disease as a man's disease, and trust me, it is. Cardiovascular disease worldwide is the #1 killer of men and women, and it's the and women that is particularly important. If we go back 60 years, actually now closer to 70 years, if I as a woman was looking for some information on women and heart disease, so I did this actually, I went online and looked, I found this brochure from the American Heart Association. How to help your husband recover from a heart attack. Seriously. And it's not that long ago. That was the extent of the information that we were making available to women. We have made a lot of progress, and so from my perspective as a researcher, I'd like to share with you some key time points that I think are really important to helping us close that gap in our knowledge. So the first one was back in 1990. So in that year, the National Institutes of Health, so this is a major research funding body in the United States, created the Office of Research on Women's Health. They recognized that women's health was not well investigated. So that was the first key movement forward. In 1993, the National Institutes of Health worked to get actual legislation called the Revitalization Act. The Revitalization Act deals with clinical trials. So for people that are physicians or researchers like myself, clinical trials provide us with the highest quality evidence to help inform how we treat our patients. So clinical trials are critically important. This legislation said you must enroll women. Legislation. Now, in Canada, 1997, because we're polite, we did not pass legislation, we just encouraged people to enroll women in clinical trials. But still, it's a move in the right direction. But we did something fundamentally important, and the CIHR stands for the Canadian Institutes of Health Research. We actually created the Institute for Gender and Health, the recognition that gender and sex is important in human health. For me, one of the most important publications was this one, and it comes from the Institute of Medicine. Sorry, that's a little bit blurry. It's the Examination of Biological Contributions to Human Health, and the subtitle is, Does Sex Matter? And I'm going to come back to this because this was a critically important publication. In 2000, oh, that's been cut off. That should say 2000, I think, 18? I'm not sure. I don't know why that cut off, Peter. Anyways, CIHR began to ask people who were applying to them for money. So remember, this body is the largest funder of human research in Canada. Began asking all of their applicants to indicate if they were examining sex and gender as part of their research project. It was simply a tick box. Are you actually looking at this? We have since strengthened that. We're not just asking, are you looking at it? The Heart and Stroke Foundation, which is the single biggest funder of cardiovascular research, and the CIHR, will no longer fund any research if you do not include women. Now, of course, there are exceptions. If you're investigating testicular cancer, you're not going to enroll women. I get that. But by and large, you should be enrolling women in your studies. It should be part of your study design. It should be part of your analysis plan, and you should report the results for both men and for women. Here's that publication. This time you can see the title a little bit better. And you can see two quotes that I've pulled out here. What the book is essentially saying is it's scientifically valid and scientifically important to investigate sex differences. For the longest time, medicine had sort of a male model of disease. It's a recognition that this is an important endeavor that we have to undertake. And the second quote essentially says, we're never really going to understand human health and how to best provide care unless we seriously investigate this. So this was really a key and pivotal publication. So we have agencies now that say you must enroll women. How are we doing? So you might, and I wouldn't blame you, off the top of your head say, well, that must mean when I'm enrolling for a study, 50% women, 50% men. I would argue there's a better way of looking at it, and I would argue that it's this thing here. What this is showing you is, in these hatched bars, this is the proportion of women in the population who have this particular disease. And in the solid bar, it's the proportion of women with this disease that have been enrolled in a clinical trial. These aren't just any research study. This is the clinical trials. Remember, we take those very seriously. They're the ones that inform how we provide care. CAD stands for coronary artery disease. So in the population, 55% of them are women. But we only enroll 30% in the trials that are looking at coronary artery disease. Similarly, non-coronary vascular, think of that as stroke, blood vessel disease. Women comprise 52% of the population with those conditions. We only enroll 37. HF stands for heart failure. Again, slightly less than half of the population is comprised of women. We only enroll 28% in our trials. And here, arrhythmias, those are just irregular heartbeats. Many of you would think have heard of atrial fibrillation, for example. That's an arrhythmia. Again, it is predominantly in women, 55% of the population, and we only enroll 28%. So we need to do better. If we get to the point where we actually enroll enough women, that's a very positive first step. But if we then publish our findings and we don't publish the findings for men and women separately, we're actually not going to move any further forward, right? Yes, I enrolled women, but I haven't told you whether there was any difference in the results between the men and the women. So finally, some of the better journals are now saying to anyone who applies to them and says, I'd like to publish my research in your journal, they're saying, we'd love to take it, but you need to report the results by sex. And some of these journals are really very prestigious. The Circulation Journal is probably, along with I think the Journal of American Cardiology, preeminent journal in the world for cardiology. The Lancet is a more general paper, but a highly respected paper. Everyone wants to publish in the Lancet and the New England Journal. Nature, Stroke, Hypertension. This is ours, the Canadian Medical Association Journal. And this is the British Medical Journal, their open one. The open one just means it's free to anybody. You don't have to have a membership. You can go online and read their papers. So, you know, we are making progress, but there's still some very important journals that are still not insisting on that. So at this point, I'd really like to share with you over the last 25, 30 years, what have we learned? Because we have made progress. We're enrolling more women. We're reporting the results by sex. So what have we found out? First of all, women have different coronary disease. When I first started my career, we learned about what are called the epicardial vessels. These are very large arteries on the surface of the heart, and mostly when people have a heart attack, it's one of those arteries that has become plugged up with plaque. This little cartoon here shows you how that happens. This is a lipid core that gets wider and wider and wider, and therefore impedes the flow of blood. And it can rupture, and if it ruptures, a clot forms, and then you completely close off the vessel. So we call that a myocardial infarction, commonly called a heart attack. That was our classic learning of what a heart attack is all about. We now understand that a significant proportion of women don't present with the disease in their large epicardial vessels. Many of them do. I don't want to mislead you to think, oh no, women don't have this. They do. But an important proportion of women do not present like this. So they will go up to the catheterization lab where they actually take a look at the inside of your vessels. Everything looks completely clear, and they get sent home and they're told they're okay. And sadly, many of them, they're not okay, and something tragic happens. The reason for that is there's a significant proportion of women who have the disease in what we call the small coronary artery network or microvasculature. These, as the name would imply, are the smaller arteries that penetrate deeper into the heart. And when we use the angiogram, you know, that's sort of almost like an x-ray on the inside of your vessels, that is optimized for this disease. It is not optimized for this disease. We can't see that. So at least we now understand that women can present with this. It is different. So here's the cartoon of what this looks like. You can, of course, still get a little bit buildup of that yellow plaque, but you can see there's a huge difference between these two. Look how much plaque there is here, how little there is here. In the microvascular disease, what happens is the wall of the artery is diseased, and you can get spasms where it closes and opens, and it never properly relaxes. You want the arteries to relax so that the blood flows freely. So as I just mentioned to you, the angiogram is not very good at detecting that, but that's our gold standard diagnostic tool. So what can we do? This is just a picture of what the cardiologist would see on an angiogram. The heart, you can't really see the shadow here because it's emphasizing the epicardial vessels. This one happens to be the left anterior descending. It's one of the biggest arteries coming down the front of your heart. So if you have a woman who presents with maybe a heart attack, but you look at the epicardial vessels and they all look normal, just accept my argument that this one looks normal, you should go one additional step and try and figure out if it's the microvasculature. Now remember, I told you you can't see it. So what do? You inject it with acetylcholine. Oh, that got shifted as well, Peter. I don't know what that is. In a normal LAD, this would stay nice and wide and open, but I think you can see this is much narrower, right, than that one. So it is vasoconstricted. That's a sign that the microvasculature is not responding correctly. So that's an additional step you have to do. They actually inject the acetylcholine right into the main artery. Of course, it diffuses down to the microvasculature, and if you see this vasoconstriction, that's an alert that you probably have microvascular disease. Unfortunately, this step is not frequently taken. The last one is just showing you to undo that. They gave this person nitroglycerin, and so you can see how this artery has opened up nicely. It looks identical to what it looked like to start. So we do at least know now how we can go about diagnosing this condition. SCAD is rare. Does anyone here know what SCAD stands for? Don't worry if you don't. I'm just maybe in case somebody did. SCAD stands for spontaneous coronary artery dissection. Because that's a long word, we love short forms, we happen to call it SCAD. This is actually an emergency condition. And what it is you get a tear in the inside wall of your artery. Our arteries and our veins have 3 layers. And normally in a healthy vessel, the blood flows right down the middle, what we call the lumen. In a SCAD, the intima, which is the interior layer, gets a tear. And now because there's a tear, the blood is flowing between this intima and the second layer, which is called the media. And it's not flowing nice and smoothly. It's pretty rough because of that tear. So it's at a high risk of forming a clot. And so that's when you really get into trouble. As I see here, it can slow or block the blood flow, and you can have all sorts of dire consequences. What's particularly interesting about this condition is it predominantly affects women. Over 90% of SCAD is seen in women, and it's mostly in women that are only 40 or 50 years old. Once they're 60s and 70s, it becomes increasingly rare. The other thing that makes it very difficult to diagnose, it can be done with an angiogram, by the way, but you have to be looking for it. The other thing that makes it difficult to diagnose is the typical risk factors that we know of for heart disease, for example, high blood pressure, diabetes, high levels of cholesterol. These people with SCAD rarely have those symptoms. So you're not getting any warnings that this might be what this person is suffering from. And when they present, by the way, they do look like they're having a heart attack. It's extremely painful, sharp pain in the chest area. So it really was believed to be rare. We thought it could be as low as 1%, maybe as high as 4% of all heart attacks were SCAD. And as I said, the diagnosis of SCAD using the angiogram is rather challenging, and unless you've actually been taught what to look for, it's highly likely that you will miss it. So I have to give credit to Jackie Saw. Jackie Saw is an interventional cardiologist here in British Columbia. She practices at Vancouver General Hospital. She is the one who's actually written the guidelines for how to use an angiogram to diagnose SCAD. And she's become a world authority on that. And she and other colleagues who have now systematically evaluated, again, mostly women, who presented with what they thought was a heart attack, couldn't find anything. We now know that SCAD may take up as much as 35% of heart attacks in women that present to hospital. So it's not 4%. It's probably as high as 35. It's certainly not any lower than 24%. I love this topic. Heart attack symptoms differ by sex. I'm sure, like most of you, my first introduction to a heart attack was a Hollywood movie with a man, never a woman, who has a heart attack, clutching the center of the chest, bent over, excruciating pain right in the middle of the chest. So an eminent medical expert, Oprah Winfrey, said, women's symptoms are completely different than men's. Well, no, they're not completely different, but it is important to know that they do differ by sex. We have this annoying term, I think Dr. Perry will be familiar with it, typical symptoms, Peter, and atypical symptoms. And we always applied atypical symptoms to women. They're not atypical, they're typical for women, and that's the important distinction. The debate about do women or do women not have chest pain is an ongoing debate. So I just wanted to share with you the results of a very interesting paper that examined this in, I think it was over 100,000 people that had presented with what we call myocardial infarction, MI, but it's a heart attack. So the way you look at this is, first of all, notice we've broken it out by age, so every age lines up this way. The second thing is, everything to the right of this vertical line means women are more likely to present with no chest pain relative to men. So you can see at every single age group, these lines are to the right of that vertical line. So women are less likely to present with chest pain. It actually looks, if you interpret it quickly, as though the biggest difference, so the odds ratio helps us with the magnitude here, 30% higher odds of not having chest pain in young women. But as an epidemiologist and someone who loves numbers, I love to dig deeper. And while that is the correct interpretation of the data I've showed you, it obscures something very important. Young women are much more likely than older women to have chest pain. Almost 82% of young women have chest pain. So while the difference vis-a-vis the men in that age group is large, and of course it's much smaller when we get to 75 to 84, don't lose sight of the fact that young women frequently present with chest pain, though they do describe the chest pain a little bit differently, and I'll touch on that in a minute. I think the other takeaway from this graph is, as we get older, both in males and females, we are less likely to present with chest pain. This is a graphic that I took off a website from the American Heart Association. I want to make 2 points and then I'll walk you through what that graphic says. So chest pain really is still the most common symptom in both men and women. Of course, it goes down as we age, but women do describe their pain differently. They don't tend to have that sharp pain in the center of the chest. They describe it as a discomfort, as a pressure. I heard one of my colleagues say one woman described it as an elephant sitting on her chest. It's not that sharp, what we call retrosternal pain. That's the first thing to understand. The other thing that we now understand is while most men will come in with one symptom, women come in with 2, 3, even 4 symptoms at the same time, which can be challenging, you can imagine, for the emergency room doctor to try and figure out. So as you can see, oh gosh, it's blurred again, I'm so sorry. Take my glasses up so I can read this. So nausea and vomiting are common symptoms, and we will find them both in men and in women. Jaw pain and neck pain is common, particularly in women. Men will have neck pain, but back pain, But women, when they have back pain, describe it as their upper back. The men don't describe it that way. As I mentioned already, the way the men describe the chest pain is that it's squeezing, it's sharp. The women always talk, it's a discomfort, it's unpleasant, it's heavy. Shortness of breath is another common symptom for a heart attack, though it's much more common, shortness of breath in women. And unique symptoms for women that you hardly ever see in men. Women will faint. Women will describe that they have indigestion. And then they also describe extreme fatigue. Now that's what we call a prodromal syndrome. That's a symptom that you describe before the event. And when I say extreme fatigue, I really mean extreme. All of us have days when we feel tired. That's not what I'm talking about. I'm talking about extreme fatigue, and it usually occurs a few days before the actual event. This is particularly near and dear to my heart, and its diagnostic thresholds are not unisex. Medicine uses a lot of diagnostic thresholds. So there's a threshold. If you're below that threshold, you're unlikely to have the disease under investigation. If you're over that threshold, you're much more likely to have that. And we use that as part of the diagnostic workup. For the test that I'm going to talk about, which is cardiac troponin, CTN, that is a protein that is released into the blood after a heart attack, because a heart attack damages the heart muscle. And when you damage the heart muscle, proteins leak into the blood, and you can measure them in the blood. So physicians will ask for a cardiac troponin test, and the level helps them determine whether or not this person has had a heart attack. Now, it's important to recognize that even in healthy people like us sitting here, if we ran a troponin test, probably in all of us we would detect some troponin. That doesn't mean having troponin is a bad thing. You want to establish a threshold where the troponin is so high that it is not consistent with a healthy heart. And by convention, that threshold is established at the 99th percentile. What does that mean? 99% of the population is below this threshold, 1% is above. If your reading is above the 99th percentile, we have a lot of confidence. This level is way too high, and you probably had a heart attack. In the last decade, we have developed a new assay called high sensitivity cardiac troponin. And probably as the name implies, it means it's much more sensitive. It can pick up lower levels. It also happens to be extremely accurate. Why is that important, that it's more sensitive and more accurate? We now actually understand that women do not release the same amount of cardiac troponin as men do for a given size of heart damage. So when we first started with this assay, this number, you probably can't see it, it says 48, was considered the 99th percentile, so it's threshold. If we measure troponin in your blood over that, we have high confidence, along with other things, that you've probably had a heart attack. But now that we have high sensitivity, we can measure it in women and in men. So let me blow that little graph here up so you can see this more closely. When we measure it with high sensitivity and we run it separately in men and women, 33 is the 99th percentile for females, and for males, it's actually 55. Well, why does this matter? Here's why. This is where 48 was. So all of these women who were above 33 but didn't hit 48, we probably sent home and said you're fine. And ironically, the men, we say you've had a heart attack, but actually it's much more likely if you were over 55. So now that we actually understand that difference, my hope is that we won't continue to underdiagnose women who have had an actual heart attack. Some colleagues of mine in Edinburgh did this study to look at what sort of a difference this makes. So this graph shows you the proportion of men in blue, the proportion of women in a sort of a peach color that had an elevated cardiac troponin, suggesting they had a heart attack. In their old non-sensitive assay, they had a cut point of 50 nanograms per mil. And I think you can clearly see they diagnosed way more men than they diagnosed women. All right? This is the proportion that were diagnosed as having a heart attack based on their troponin level. Then they adopted the high sensitivity one. It has a lower threshold now of 26. So you won't be surprised, we're picking up more men, but thankfully we're also picking up more women. But now look what happens when you take this same high sensitivity assay and apply the sex-specific thresholds. Now this is a different assay from the one I showed you before, so the thresholds are different. In the men it's 34, in the women it's 16. Look at what happens to what I call the diagnostic yield. You have essentially the same number of men and number of women. So you've been missing these women previously by not using the right diagnostic tool. Actually, I'm running a little slow, so let me just skip over that one. I found this really intriguing, and so I applied to CIHR, the Canadian Institutes for Health Research, to do a trial that would actually examine the impact of using the female-specific cut point, which no matter which assay your hospital is using is always lower than the threshold that should be applied to men. Would we finally do a better job of diagnosing women? And of course the hope is if you get the right diagnosis, you'll get better treatment, and if you get better treatment, you should have better outcomes. So we were very fortunate. We did get the funding to do that. We have 28 major hospitals in Canada in 8 different provinces running this particular trial right now. We hope to have all of the data collected by the end of March in 2025. And with any luck, Peter, if all the ducks are in a row by the end of 2025, we hope to publish our findings. And I genuinely hope that making that simple change hospital-wide using the correct cut point for women will not only do a better job of diagnosis, but will then treat them better and hopefully have better outcomes.
And we'll have to have you back.
I'd be delighted. Do men have better outcomes? So this really is what got me involved in women and cardiovascular disease. That no matter which journal I read, whether you had open heart surgery, whether you had angioplasty, the women always had worse outcomes. The men just did better. And I really wanted to understand why is that. This is a really interesting trial. This is a trial done in people who've had a heart attack. It's a particular heart attack that's a very severe heart attack called a STEMI. It just stands for ST elevation MI. It's ST is a wave on your ECG that identifies that the heart attack you've had has gone through the entire thickness of the muscle. So it's a very severe heart attack. And the appropriate treatment for that is something that we call primary PCI. PCI is percutaneous coronary intervention. It's just a fancy name for an angioplasty. Are most of you familiar with the concept of an angioplasty? No? Okay. What we do is, it's much less invasive. What we do is we feed a hollow tube called a catheter up the femoral artery. It used to have just a balloon on it. Now it has a balloon and a stent, which is like a wire cage on the balloon. You feed it up into the heart. You place it under, visually you can see where you're going. You place it over where that blockage is. Remember that diagram with that thick plaque in there? And then we open the artery and we leave the stent behind. So we've now moved the plaque out of the way. We've kept the plaque out of the way with a stent. And so that's one way to treat it. So this is a trial that looked at that. Now primary PCI is for these STEMI types of MIs, and it should be done very quickly. So the moment you're diagnosed, you should literally go straight up to the cath lab and they should intervene immediately. And this study was actually looking at some anticoagulants, but they had the wisdom to go back, look at their trial data and say, we collected whether or not they're male or female. Is there any difference? And yes, there is a difference. So the way you read this graph, this is your outcomes at 36 months. So from the time you had your primary PCI out to 3 years, what happened to you? We're looking for what they call MACE, Major Adverse Cardiovascular Event. For this study, that's defined as you died, well that's pretty severe, or you had another heart attack, or you had a stroke, or you had such terrible symptoms from your blocked artery that we had to take you back to the cath lab, give you another stent, and it was really urgent. So if any of those things happen to you, then as we follow you up, every time one event happens, the line goes higher and higher. Now, the women are in the red, the men are in the blue. I think you can clearly see the women did worse. And when they actually examined their data to try and understand why that was, there were a couple of obvious things. The women were sicker. It's important to acknowledge the women were likely to have diabetes. The women were more likely to have high cholesterol. The women were more likely to have hypertension. They were older, but a really important one was the women did not present to hospital as quickly as the men did. And that is very much a social construct. If my husband had a heart attack, I would not hesitate to call 911 immediately. If a woman has a heart attack, well, you know, Johnny has to go to the hockey game and I need to get dinner ready, and then, well, there's probably nothing wrong with me. We really delay. We really hesitate. We don't want to acknowledge. If you take nothing else away from today, please, if something doesn't feel right, ask for help immediately. The sooner you get to the hospital, the better you will do. So this is one of the explanations for why the women did worse. On average, the men showed up within 3 hours of the symptoms. The women showed up on average within 6 hours of the symptoms. That's a huge difference. And that has an impact on what's going to happen to you later. The other thing that this study really highlighted is that women have way more adverse events. So now we're not talking about dying and stroke and another heart attack. We're just talking about what happened to you immediately after you got the angioplasty. The only thing that was not different between women and men was an intracranial bleed, so a bleed within the brain. It's very low, thankfully, 0.3%, and the same. But if you look down here, all these things, major bleed, retroperitoneal bleed, access site hemorrhage, a significant drop in your hemoglobin, and the need for a transfusion, every proportion is larger in women than it is in men. And for someone like me, I love to look at p-values. All of these tell me I can believe these differences are real. They're not trivial. I want to leave you with a good news story because there's a lot of bad news. And it is important to acknowledge the good news stories. And this is a story about TAVI. Has anyone heard of TAVI? I think I saw someone, yeah. TAVI stands for transcatheter aortic valve implantation. As we age, we're at greater and greater risk of the aortic valve getting narrower and narrower, and it can often get calcified. This is a picture, a cross-section of an aortic valve. It has 3 flaps. This one is apparently wide open. Now, the aortic valve is really important. This is your left ventricle. This is the aorta. This is the freshly oxygenated blood that is going through the aortic valve and being distributed to the rest of the body. It's critically important that you have good blood flow. Well, good blood flow everywhere, but very important here. If you have aortic stenosis, stenosis just means a narrowing, possibly with calcium buildup. You can see this isn't opening properly. In a healthy aortic valve, these flaps would be peeled back completely and there'd be beautiful laminar flow through that aortic valve. Before TAVI came along, you had to undergo aortic valve surgery, which is open heart surgery, which means we have to saw through the sternum, kind of peel back your rib cage, take out the diseased valve, put in either a new mechanical valve or a tissue valve, and then sew you back up, staple your sternum together, and it's serious surgery. TAVI is kind of an extension of an angioplasty that I told you about, where you run a catheter up the femoral artery into the heart and leave a stent behind. It builds on that concept. And again, we have a leader in British Columbia who is largely responsible for developing this. His name is Dr. John Webb. He's actually at St. Paul's Hospital. He did some of the major development in this. Same idea as with the angioplasty. You feed a hollow tube up, you have a new valve wrapped around a balloon. You position that new valve with the balloon right where the diseased valve is, so you're essentially pushing all this stuff aside, you're opening it as wide as you can. You deflate the balloon and you leave the new valve behind. You pull out the catheter and you've got a new valve. It's really a major, major breakthrough in medicine. Why I'm excited about it is Dr. Webb allowed me to look at his own data because St. Paul's was a hub for this procedure. And so I did look at that data and I looked at simply survival. Now, most of the people who underwent this TAVI procedure when I was looking at the data were in their early to mid 80s. This was an older group of people. We first developed it in that. They're actually getting younger and younger now. It's being offered to more and more people. And so I looked at what were the chances that you were going to die, and I stratified it by female and male. Females are red, the males are blue. So this is a little opposite. The way this works is if you die, you drop lower. So the line that drops the lowest has the worst outcome. So we're actually showing that women who undergo TAVI have a significantly better outcome than the men do, 40% better. With the open heart surgery, the women did much worse. But we finally have a procedure that actually benefits women more than men. It still benefits the men, don't misinterpret that. But the women get even more benefit from this procedure than the men do. I think many of you have read the headlines that myocardial infarctions or heart attacks are declining, and they indeed are. Again, I wanted to share with you BC data. It is a little bit out of date, but trust me, the curves are not that different. But I really wanted to show you data from our own province. A colleague of mine and I worked on this. We looked at acute myocardial infarction, so heart attack admissions to hospital per 100,000 population in British Columbia from 2000 to 2009. And I think you can see, is particularly in the men, there's a really nice decline in the number of hospitalizations. So you can take that as a marker for improvement in the risk of having a heart attack. And while that is true, and it is, by the way, true universally, the rates are coming down. Again, as epidemiologists, we like to drill a little bit deeper. We decided to break it out by age. So let me draw your attention to B, C, and D. Again, the men are in blue, the women are in red. And I think you'll agree with me, with all of these three graphs, the lines are going down. So certainly for anyone 56 years of age and older, heart attack rates, hospitalizations for heart attack rates are going down. But I want to blow up panel A, because these are the young people. So with the young men, it's essentially flat. The young women, disturbingly, the rate is going up by 1.72% per year. This confidence interval just tells me that this is a real significant difference. It's not just in British Columbia. When we did this paper, we reached out to colleagues in Ontario. They're seeing exactly the same thing. About a year after we published this work, the French published, the Danish published, they're all showing the same thing. It's going down throughout the entire population. It is not going down in young women. There's a couple of hypotheses about why that might be. There has been a disturbing uptake in smoking amongst young women. They're getting heavier, their BMIs are going up, they're getting more diabetes at a very young age. It's very much a lifestyle issue for the young women. So, not good news. And again, not unique to British Columbia. We have seen others all around the world publishing the same findings. So I want to end with just a couple of bullet points because we have limited time and I know I'd like to leave time for questions. This is another thing that we've only recently understood about heart failure. So heart failure is broadly broken into two categories. It's HFrEF and HFpEF. That's a mouthful. HFrEF, the R stands for reduced. So heart failure with reduced ejection fraction. Ejection fraction is the measure of how much blood leaves your heart every time your left ventricle contracts. Normal is about 60-65%. So most men present with HFrEF, reduced ejection fraction. But an awful lot of women present with HFpEF, which stands for preserved ejection fraction. Our treatments from heart failure, they're by and large very good, but they're all optimized for HFrEF. So we have a lot of work to do to try and find treatments for HFpEF, which predominantly affects women. In elderly women, as I've showed you with John Webb's work for aortic stenosis, TAVI is the preferred option to open heart surgery. I think many of you may still remember the literature. There was a big study done on Harvard physicians, and the conclusion of the Harvard study was that men should take an aspirin every day. It reduces their risk of a heart attack. It wasn't until the NIH funded the Women's Health Initiative that we learned that's not what happens in women. It does, interestingly, reduce the risk of stroke. But again, a real illustration of why you can't just take the results in a group of men and apply it to women. We really need to look at women separately. Remember when I told you about that microvascular type of coronary artery disease in women? It can still present with a heart attack, which we call MINOCA, which stands for MI, which is myocardial infarction, in non-obstructive coronary arteries. So you can still have a heart attack even though all the disease is in the microvasculature. It is 4 times more common in women than it is in men. Men do get it as well, but it's 4 times more common in women. And I think I mentioned this before for SCAD, spontaneous coronary artery dissection, 90+% of SCAD is found in women, and it's in young women. And lastly, there's another type of heart attack called NSTEMI. Remember I mentioned STEMI, the one that shows it went through the entire wall. NSTEMI is considered slightly milder, and there were a lot of studies that said, well, maybe even with this type of heart attack, we should rush them up to the cath lab and treat them right away. Yeah, it's actually very good for the men, but it's not very good for the women if they're low risk. So with men, low risk, high risk, send them to the cath lab, do an angioplasty, send them home. With the women, only send the high risk women. Don't do it for the low risk women. They don't benefit from it. So with that, let's just quickly summarize. So I do think we've made significant advances in our understanding of sex differences and disparities. But I've described a lot of differences to you. I haven't been able to share with you a lot of things that we can do about it. So I think that's an important next step for my colleagues to work on. As I mentioned, randomized controlled trials, we have to enroll more women. And we need to enroll women proportionate to the proportion of women that have that disease in our populations. And of course, we absolutely have to report that in our journals. So with that, I want to end by first thanking the organizations that helped fund a lot of my work, and very importantly, the extraordinary team of people that I have worked with. So thank you so much for I hope there's some questions.
Do you attend the question?
Yeah, I think so, right?
Sure.
Yeah. Yes.
Yeah, so if men are encouraged to take an aspirin a day, what dosage are women encouraged to take?
Yeah, I don't want to tell women to start taking aspirin. First of all, I'm not a physician. With every medication, there is a risk. There is a high bleeding risk. You really need to talk to your physician who knows your personal health history to determine whether you should take an aspirin or not. I was really trying to illustrate that you need to pay attention whether it's males or females, but that is not an endorsement for women to take an aspirin a day for stroke. Yes.
How much does genetics play in women? Because I myself had a stent a year ago, and I didn't wait 6 hours, I waited 3 days, because I'm very fit. Didn't have high cholesterol, and the whole time I was in the hospital, they were doing troponin and ECG.
Right.
It was always normal, and they said the only way we'll find out would be if you had an angiogram. And my LAD was 95% blocked.
Oh my.
And he told me it's the widowmaker.
Yeah, that is what it's called.
And they said it must be genetic because your cholesterol it was not even high.
Yeah. It's hard to say. I mean, genetic plays a role in everything, but a lot of it is also lifestyle. But you clearly do not look like a person who would have a heart attack, and many of the women who don't look like that. I don't know that I can tell you why that is. The fact that your troponin was low doesn't surprise me. You came in at 3 days. Troponin rises and then it drops, and they measured you when it had already dropped.
They kept measuring it.
Yeah, and it didn't change.
It never changed.
Yeah,
because it was always normal.
Yeah.
They said it was always normal.
Because you waited too long. Had you gone in at 3 hours, or even as late as 6 hours, they would have still seen a rise, and then they would have seen a decline, but you were already down into the normal range again. So that's why they couldn't see it. I am glad that they nevertheless sent you up to the cath lab, So that was a good move.
Yes,
This is the only way they would know.
No, and so it was a real lesson to me and to
Yeah.
my other family members
Yeah.
that I was poo-pooing it. I thought it's just the
It's-
heat, anxiety, or
It's a typical response. Yeah, and I think as women, we need to unlearn that, right? If it doesn't feel right, it isn't right. You know, often we hear women say, oh, I didn't want to bother the ambulance. You know, maybe it's nothing. They don't mind being bothered. It's not an issue for
that's
them.
what they asked me. They said, why did you wait 3 days? And why didn't you tell your husband? I said, because I knew he'd call 911. I did not want to make a spectacle
There
of
you go.
myself by
See?
being helicoptered
Yeah.
off the island and blah, blah, blah,
Yeah.
blah. And
Yeah.
it was stupid. And the cardiologist told me you could have just dropped dead at any moment.
Yeah.
So
So what were you feeling like?
I just kept getting chest pain from time to time. But with me, it went right across, under both arms, down both arms, and do my job. But it would go away,
Yeah.
and I'd feel fine. I'd think, well,
And then you dismissed it. Yeah. Yeah. So please don't do that. Please call 911. Yes.
If in our families there's a large history of heart disease in the women, should we take extra precautions?
Yes, family history is an important predictor of risk. It does put you at a higher risk. It's something you really need to discuss with your physician. That's another really important thing that's not my research, but others have shown that usually when a man goes to a GP, they test the cholesterol, they check all the risk factors for heart disease, and many of the GPs still don't ask questions about risk factors in women. And family history is a very important one, so make sure that your GP knows that. Yeah.
You presented incredibly interesting information, and I can't remember enough. Is there anything I can read or any way I can revisit the material?
Yeah, so Peter, do you want to mention?
Well, the presentation will be on the Pender Healthcare, Healthcare site, right? So Earth, when will it be up?
Well, as soon as we get the video, we will put it up on the website, and that may take a few days, but you can definitely re-see the whole presentation.
Yeah, so please revisit
Thank
it as
you.
many times as you want.
Yeah, thank you.
I don't know if you noticed, I left some references for some of the studies. You can actually look those up if you do want to read a bit more. Okay. I think we're good.
Question?
One here.
Oh, sorry. I'm sorry, I didn't see you.
Can you please repeat
Yeah.
the additional symptoms for women and they're most important
Yeah.
and they're most liable to be experienced? Can you do that?
So I don't want to say the most reliable to
Well, all
be.
right, just
Yeah, but the fainting is an important one in women. That's one. Let me just bring up the graphic for you so you can see it. Sorry. Here we go. There you go. So again, remember two things. The women will describe the chest pain a little bit differently. It's not sharp, it's not crushing. It's usually a heaviness. I don't know if that was the case for you. The jaw pain is very, very typical. Upper back pain is very typical. The fainting is completely unique to women. Difficulty breathing. You have trouble getting your breath is a very common symptom in women. So you'll see this when it goes up on the web, and you can make a copy of that. But those are the important ones to remember. That, and I guess the other thing is that prodromal one that occurs before the event, the extreme fatigue. An awful lot of women say, gosh, I don't know what's wrong with me. I've never been this tired in my entire life. That's a real warning sign that you need to pay attention. Yeah.
Is there any other markers that we could be aware of before that? Like high blood pressure or
Yeah, I mean,
what are
yeah.
the other things before all of this?
So I would say these aren't markers, but if I'm answering your question correctly, there are things that are risk factors that increase the likelihood that you could have a heart attack. So family history is a very important one.
Okay.
In women, diabetes is a very important risk factor. It's a risk factor in men and women, but the impact of diabetes is stronger in women than it is in men. Another one, I think everyone here, if I said smoking is a risk factor for what, they would say lung disease. It's important that you understand it's a very important risk factor for heart disease. And it's another one where smoking has a much worse impact in women than it has in men. And of course, high blood pressure and also high lipids. Those are the classic ones. Yeah.
Okay, great. Thank you.
You're very welcome.
Karen, I noticed in the earlier slide you showed that coronary artery disease was like 55% in women and
Yeah, less in men.
less in men. And
Yeah.
yet, when you show your incidence of heart attacks in BC, like the men's were 4
Yeah.
times higher. So
It's
how
a-
do you?
How do I reconcile that?
Yeah.
It's a very good question, Peter. So remember it said CAD, so
Yeah.
it's not just myocardial infarction. It's actually myocardial infarction and coronary artery disease, whether it
angina
leads
and-
to
yeah.
whether it leads to a heart attack or not.
Right.
That's why it's higher in women. Very good observation. He doesn't miss much. Yeah, oh, sorry, go ahead.
I noticed in one of your slides that the 36-month outcome
Yeah.
time, at about the 12 or 13-month point, there was a little uptick in both the men and the women in terms of adverse outcomes.
Oh, was there?
Yeah, and I just wondered what that means.
Was that the Horizon AMI? You know, it might not be significant. Is it, no.
It's probably.
That one,
Yeah,
that one,
that's
you see
Probably
that?
we know the
Oh,
financial.
there, yeah.
Financial.
Yeah, you're right, at around 12 months, and then it sort of levels out.
The other thing about that graph is the difference shows itself early
Yeah,
and then stays the same. So it's
yeah,
going along with the idea
yeah,
that it was not getting there on time.
good
But
point.
the ones who got there in time then subsequently had
Yeah,
the same.
catches up in the end,
Yeah.
yeah. That's a very good point that Peter made. Notice how these lines go up sharply immediately and much more sharply in the females. And I think that delay to presentation is what's driving that line up very, very quickly.
But Kelly's observation is very interesting.
Yeah,
The jump
yeah, you're
up
right,
in those
and it's in
males
both,
both.
right? It's in both, yeah. I don't know. You've intrigued me, I'm gonna dig deeper. See what it is.
Stanley Cup playoffs.
Yeah, all that stress. And they were both watching the TV, yeah. Yeah. Yes,
Last time I took a CPR course, the instructor said that symptoms for women include this overwhelming sense of doom. Can you
I've
relate to that
that.
or explain that?
No, I've heard of it before. In the reliable sources of information like the American Heart Association, that it is never listed as a risk factor. That doesn't mean it doesn't happen, but I think the evidence to support that as a consistent symptom in women just isn't there, and they're cautious about what they put in. I have heard of it before, but you know, it doesn't matter if you look at the Heart Association or the AHA or the British Heart, they don't mention that. Yes.
You talk about the symptom where you get the extreme fatigue a few
Yeah.
days before you're
Yeah.
If you're feeling that, is there something you should be doing about it?
Yeah, I think you should. I mean, that's not an urgent, I need to call 911, but I think that is, you really want to see your physician as soon as possible. Yeah. Yeah, it's not urgent, oh my gosh, I'm going to have a heart attack tomorrow. But it is a warning sign that something is not quite right. And you will know the difference. The women that have described this say it's a fatigue like you have never experienced before. It's very dramatic. Okay, I think we're right on time, Peter. 2 o'clock. Well, thank you very much.